All right, let's jump right into it. Welcome to this highly targeted explainer on acute ocular pathologies and sudden vision loss. Look, when a patient presents with an acute visual deficit, the clock immediately starts ticking. You are quite literally racing against irreversible tissue destruction. So today, we're going to strictly break down these high-yield ocular emergencies, examine the intricate mechanisms driving them, and map out the exact discrete management steps you need to take to save a patient's sight. Let's start with the embolic strike. If a patient tells you they've had a sudden, profound, and entirely painless loss of vision in just one eye, your clinical suspicion needs to lock immediately onto a central retinal artery occlusion, or CRAO. Think of this as the ocular equivalent of a severe ischemic stroke. The driving mechanism here is almost always embolic. We're usually talking about a piece of an atherosclerotic plaque that broke off from the ipsilateral carotid artery, or maybe a cardioembolic event from atrial fibrillation. That embolus travels right up the ophthalmic artery, completely blocks its central retinal branch, and just instantly starves the retina of oxygen. And that really sets up the critical divergence between our two major vascular occlusions, CRAO versus CRVO, which is central retinal vein occlusion. You have to understand the distinct pathophysiological drivers here. Like we just talked about, CRAO is an embolic arterial blockade. The blood supply is entirely cut off at the source, causing acute ischemia. But on the other side of this matrix, CRVO is driven by a venous thrombotic backlog. So the blood is entering the eye just fine, right? But an acute thrombosis in the central retinal vein stops it from leaving. That creates this massive pressure buildup and fluid stasis inside the delicate retinal vasculature. Now, what's fascinating is how these distinct mechanisms physically show up. Imagine you're faced with two patients. Both have sudden, painless monocular vision loss. How do you instantly tell them apart? Well, you look at the absolute pathognomonic fundoscopic markers. In CRAO, the retina is completely starved of blood. It looks pale, it looks opaque, and you'll see this classic cherry red spot right at the fovea. That spot is literally the only area still getting collateral blood flow from the underlying choroid. CRVO, on the other hand, presents with a violently congested retina. The venous backlog causes all those vessels to engorge and rupture, giving you this strictly pathognomonic blood and thunder appearance. We're talking massive, widespread retinal hemorrhages, tortuous veins, and cotton wool spots all over the place. So how do we handle the arterial occlusion? A CRAO is an absolute drop-everything medical emergency. To restore ocular perfusion and stop permanent blindness, you are operating inside a highly critical 8-hour thrombolysis window. The strict, emergent management steps you must mandate before doing anything else are immediate ocular massage and high-flow oxygen. Why? Because ocular massage physically fluctuates the intraocular pressure, which might just dislodge that embolus further downstream so you can restore flow to the macula. Meanwhile, the high-flow oxygen is desperately trying to sustain that ischemic retinal tissue. Moving right along, let's get into the pressure matrix, the glaucoma divergence. We really need to heavily contrast the two primary ways glaucoma manifests. Open-angle glaucoma is this chronic, insidious, mostly asymptomatic progression. It happens when a diseased trabecular meshwork slowly decreases fluid drainage over time. That leads to painless cupping of the optic disc and a really gradual loss of peripheral vision. But acute closed-angle glaucoma, that is an emergent, highly symptomatic crisis. This happens when the natural flow of aqueous humor gets abruptly and physically blocked, causing a massive, dangerous spike in posterior chamber pressure. You absolutely must recognize the classic acute closed-angle presentation the second you see it. Your patient is going to be in agonizing pain, severe eye pain, often with a headache, extreme nausea, and vomiting. They'll tell you their vision is blurred and they're seeing halos around lights. And when you do your physical exam, the affected globe is going to feel rock hard to palpation. You'll see a hazy red eye with a fixed, mid-dilated pupil. Keep in mind, this whole cascade is often triggered when the pupil dilates, like when they walk into a dark movie theater or during high-stress situations. That dilation physically bunches up the iris and completely obstructs the drainage angle. And that brings us to a massive diagnostic trap. Listen closely. Under no circumstances should you ever administer atropine or any other mydriatic agents to these patients, because pupillary dilation is the exact mechanical trigger that bunches up the iris and blocks the angle. Giving them a dilating agent like atropine will disastrously spike their intraocular pressure. You will rapidly accelerate irreversible damage to their optic nerve. Just don't do it. Because this is a true emergency, the pharmacological steps you need to lower that pressure have to be deployed rapidly and sequentially. First, you push intravenous mannitol. It's an osmotic diuretic and it acts immediately to literally draw fluid out of the eye. Second, you give acetazolamide, a carbonic anhydrase inhibitor, to slow down the production of aqueous humor. Third, you hit them with topical agents. Timolol further decreases fluid production, and pilocarpine actually constricts the pupil, which physically pulls that bunched-up iris away from the drainage angle. All these medical steps, they're just buying you time. You need that time to perform the ultimate curative procedure, which is a laser peripheral retidotomy. All right, let's shift gears to chronic degradation and look at the retinal signature. Take a close look at this. This is the pathognomonic visual for dry, age-related macular degeneration, which happens to be the leading cause of permanent, bilateral vision loss in the elderly. You see those discrete yellow deposits under the retina? Those are called drusen. It's an extracellular lipoproteinaceous material that just builds up under the retinal pigment epithelium. As this incredibly insidious disease progresses, it causes a strict, painless, and just devastating loss of central vision while totally sparing their peripheral vision. Now, we also need to compare the specific retinal signatures of two massive systemic diseases: uncontrolled, long-standing diabetes versus a severe hypertensive crisis. In diabetic retinopathy, the damaged capillaries actually leak, so you'll see strictly round hemorrhages, hard exudates, cotton wool spots, which are basically localized infarcts, and eventually this really destructive neovascularization. On the flip side, severe hypertensive retinopathy looks different. It presents with linear or flame hemorrhages right in the nerve fiber layer. You get constricted arterioles, and most famously, an accumulation of exudates that line up in a radial pattern around the fovea. That's what gives you that highly characteristic macular star appearance. Okay, let's put it all together. Time for the master case assessment. Let's test your clinical integration. Here is your patient profile. A 72-year-old female presents with sudden monocular vision loss. She literally describes it as a curtain falling over her eye. But on your review of systems, she casually mentions recent jaw pain when she's chewing, stiffness in her shoulders every morning, and a brand new right-sided headache. Given this exact presentation, what is the strictly mandated next step in her management? If you're under exam conditions, you're going to be faced with 5 highly competitive options. Do you order a carotid duplex ultrasonography? Do you administer immediate high-dose corticosteroids? Do you initiate ocular massage and high-flow oxygen? How about a CT angiography of the head? Or do you schedule an immediate temporal artery biopsy? To get this right, you have to completely deconstruct the diagnostic trap here. That curtain falling symptom, that is the classic textbook description of amaurosis fugax, which heavily points toward transient carotid atheromboly. If you stop reading the vignette right there, you're going to order a carotid ultrasound. But you can't ignore the systemic inflammatory markers. The jaw claudication, the morning stiffness, which screams polymyalgia rheumatica, and the new headache, all of those strictly mandate a vasculitis protocol. Guys, this is temporal arteritis until proven otherwise. Let's break down the execution matrix here, because we've identified this as temporal arteritis. Choice 2, immediate high-dose systemic corticosteroids, is the absolute correct answer. Why? Because the inflammation in the cranial branches of the external carotid artery is threatening to immediately extend to the ophthalmic artery. If it does, that causes an irreversible central retinal artery occlusion and she goes permanently blind. Now, choice 5, the temporal artery biopsy, that is the ultimate trap. Yes, the biopsy is definitively required for a formal diagnosis, but it must never, under any circumstances, delay the start of vision-saving steroid treatment. We need to cement this absolute clinical rule into your practice right now. When you are evaluating suspected temporal arteritis, your primary directive, your only real job in that moment, is the prevention of imminent visual destruction. Never delay systemic steroids to get a biopsy when monocular vision is actively threatened. The histopathology of that temporal artery will actually remain diagnostic for up to 2 full weeks, even after you start the steroids. So the rule is simple: treat first, biopsy second. As we wrap up this explainer, I want to leave you with something to really think about. In the heat of a clinical emergency, when multiple pathological pathways, whether they're embolic, thrombotic, pressure-driven, or autoimmune, all converge to threaten a single delicate structure like the optic nerve, how do you instantly filter out the noise? How do you prioritize the exact mechanism that will permanently destroy that tissue in just a matter of hours? Honestly, mastering that specific prioritization is exactly what elevates a good clinician into an exceptional one. Keep reviewing these intricate mechanisms, respect those strict management windows, and stay sharp. See you next time.